cells invade the bone marrow. So in those lymphoid neoplasm, there are three categories: lymphoid neoplasm, which include non-Hodgkin lymphoma and Hodgkin lymphoma, lymphocytic leukemia, and plasma cell dyscrasia. In this one, you see the multiple myeloma. So I've seen that there are two types of lymphoma: Hodgkin lymphoma and non-Hodgkin lymphoma. Let us see the Hodgkin lymphoma. Hodgkin lymphoma is a sine qua non for Hodgkin. The sine qua non for Hodgkin lymphoma is the presence of red Steinberg cells. This is a large cell with an enlarged neutrophil nucleus, exceptionally prominent nucleoli, abundant usually eosinophilic cytoplasm. So the red Steinberg cells are common in the mixed related subtype, we're going to see them, and uncommon the nodular sclerosis subtype, and they are in the lymphocyte predominant subtype. These two subtypes are other characteristic. They have other characteristic of red Steinberg variant. So, for example, this one classically, this you can see patient suffering from lymphoma. This is an enlarged lymph node. The general symptoms, normally lymphoma is characterized by fever, weight loss, loss of appetite, but don't feel, in the case you have a fever, weight loss, and loss of appetite, you are in the case of lymphoma. This is the general symptoms. Another one is night sweat, pruritus, and lethargia. Lethargia, you know, that is like a fatigue. So the lymph node, the lymphoma is characterized by enlarged, painless, non-tender, superficial lymph node. Underline here, non-tender. Once you found a big lymph node, more than 3 centimeters of diameter, which is painless and non-tender. Hope you know what is non-tender. You have seen it in your clinical skills. In that case, think that you are dealing with lymphoma. But when you found a lymph node less than 2 centimeters, which is painful, most of the time it is reactive. They say it is alcohol-induced pain, but this one it is written in the book, but there is no evidence. The cause is unknown. They say the pain typically occurs within a few minutes after the ingestion of the even amount small of alcohol. So the symptoms, sign, we have seen the symptoms, now let us see the signs. Lymphadenopathy, most of the cases they had is lymphadenopathy. Mediastinal mass, what you call B symptom, fever, weight loss, and night sweat. They are also characteristic of TB, hepatosplenomegaly. And most of the cases of Hodgkin lymphoma, the most involved are cervical and supraclavicular in 75%. And bone marrow is involved in 5%. And the bone marrow, it is involved most of the time, it is associated with. As you have seen in the morning, on that lymphadenopathy, you can do an FNA, immediately screen for the lymphoma. When you do use excisional biopsy, image-guided biopsy, can do the chest X-ray, for example, for mediastinal mass, CT scan, thorax, abdominal, pelvis, and bone marrow biopsy. Treatment of the lymph node, what you must keep in your mind until you will die, there is no surgical treatment for lymphoma. please do not do surgical operation on the lymphoma. Lymphoma is treated by radiotherapy, combination of chemotherapy. There is no need of doing the surgical incision for lymphoma because with the chemotherapy, the tumor can shrink until the end. So they say if appropriate treatment, about 85% of patients with Hodgkin lymphoma, they are curable. So this is an image of red Sternberg cells. And here, this one is for H&E, this one is for immunohistochemistry. Red Sternberg cells we have seen before. They have two mirror images, nuclei or nuclear lobes. Each contain a large inclusion like acidophilic nucleus surrounded by a clear zone. And the features that impart what we call all-eye appearance. Here there is the classification of those Hodgkin lymphoma. There are 5 subtypes of Hodgkin lymphoma. Classical one, there are 4: nodular sclerosis, mixed cellularity, lymphocyte depleted. This one is very rare. The lymphocyte leach. Hodgkin lymphoma, they are positive in immunohistochemistry to CD30 and CD15. The fifth subtype is nodular lymphocyte predominant. And what you must know, all Hodgkin lymphoma, they are B cells, not T cells. This is why they are positive to CD20. A Hodgkin lymphoma encompasses a distinct group of neoplasm that rise almost available in a single lymph node or chain of lymph node and spread characteristically in steps of fashion to the anatomical contiguous node. Despite those features, there are also some molecular studies about the subtype of those lymphoma. This is a classic Hodgkin lymphoma. This is red Sternberg cells. It is beloved. You can also found unicreated with one cell, like this one. And multinucleated, this one. With the subtype, let us start by the lymphocyte leach. Lymphocyte leach subtype is characterized by the presence of red Sternberg cells scattered against a nodular tissue's background composed of small lymphocytes, particularly devoid of eosinophils and neutrophils. A nodular sclerosing Hodgkin lymphoma, most common form, and most of the patients are adolescent and young adolescent. And the overall prognosis is excellent. So this is why we have to characterize lymphoma to predict the prognosis. The presence of particular variant of RS, the lacuna cells. This is a large and has a single metabolite nucleus with multiple small nuclei and an abundant pale staining cytoplasm. This one. See red Sternberg cells. Around there are so many lymphocytes and without neutrophils and eosinophils. A nodular sclerosing, you see on the image the nodules, and here there are fibrous tissue, what we call sclerosis nodule, and here it is sclerosis. Mixed cellularity Hodgkin lymphoma, most common form of Hodgkin lymphoma in patients older than 50 years. The overall comprise 25 cases. There is a male predominance. This one, I don't know why. A classic red Sternbergs are plentiful within a distinctive heterogeneous cellular infiltrate which includes small lymphocyte, eosinophils, plasma cells, and the benign histiocyte. This is why it is called mixed cellularity, because there are lymphocyte, eosinophils, plasma cells, the benign histiocyte. For example, this one. Here there's some lymphocyte and some eosinophils and some macrophages around. Lymphocyte depression group, this is the least common form of Hodgkin lymphoma, amounting less than 5%, characterized by paucity of lymphocyte, and relative abundance of Steinberg cells in their promorphic variant. Immunophenotype of red Steinberg cells is identical to that seen in other classical type of lymphoma. Immunophenotyping is essential since most tumors affected being lymphocyte depression. In this case, red Steinberg cells (LIS) are affected by EBV Epstein-Barr virus. The lymphocyte depression Hodgkin lymphoma occur predominantly in elder HIV patients, and they also found in non-industrialized countries. Advanced stage and systemic symptoms are frequent, and the overall outcome is somewhat less favorable than the other type. So this is the lymphocyte-depleted Hodgkin lymphoma. You see there are so many LIS, red Steinberg cells. This one, another one is lymphocyte predominant with popcorn LIS. 5% of Hodgkin lymphoma, with a large number of small resting lymphocytes, mixed with variable number of the histiocytes. A classic LIS are extremely difficult to find, but there is a variant called popcorn. I hope you know those popcorns form. They have popcorn. The cells they have shape of popcorn, and what you must know, they have an excellent prognosis as a nodular sclerosis. Unlike the red external variant, this variant, there are B cells, they express CD20, but usually they fail to express CD15 and CD30. Most of patients with this subtype present with isolated cervical or axillary lymphadenopathy. They have said the prognosis is typically excellent. So this is like a popcorn. Here it is clear. Popcorn LIS, characteristic of lymphocyte predominant. So apart from those Hodgkin lymphoma, there is also non-Hodgkin lymphoma. For those non-Hodgkin lymphoma, clinically, both they have lymphadenopathy like this one, but on the clinical features, you can suspect it is Hodgkin lymphoma, but it is not clear. You have to use those investigation of finding needle and biopsy. Non-Hodgkin lymphoma, they are more common than Hodgkin lymphoma. Median age is between 65 and 70. There is predominance in male. More often clinically disseminated at diagnosis. Most of them, they are B cell 70% and T cell 30%. This is why when you found it is non-Hodgkin lymphoma, you have to do immunohistochemistry to see if it is B cell or T cell lymphoma. Once is T cell lymphoma, this one has a poor prognosis compared to B cell lymphoma. Clinically, they say widely disseminated at the presentation, nodal involvement, painless lymphadenopathy, often on cervical region, can find hepatomegaly, extranodal, intestinal lymphoma, abdominal pain, central nervous system, headache, cranial nerve pulse, and spinal cord compression. There's also a skin, can find also in the skin, the testes, thyroid, and bone marrow. Whereas those of Hodgkin lymphoma, most of them they're found in the lymph node. And this one, in case of bone marrow, they found pastopenia, means that this reduction of lineage of the cells. Clinical features, they're associating weight loss, itching, like Hodgkin lymphoma. There is hyperuricemia, hypercalcemia, and also renal failure. Can find some gut obstruction and ascites. For the classification, they have low and high grade. Low grade, you don't see the symptoms clear, and the treatment is not treated as low grade, whereas high grade, they are potentially curable. So for you, it will be hard to grade lymphoma, but for the main job of a pathologist to say it is low grade or high grade, because they are criteria. The etiology, the cause, there are several causes. This is where they say cannot be attributed to a single cause. There are some chromosomal translocation from 15 to 18, like those in the Burkitt lymphoma. There's some virus involved, like EBV, Epstein-Barr virus, human lymphoblastic virus, HIV. There's some bacteria involved, the Helicobacter pylori, which can cause the gastric lymphoma. Immunology, congenital immunodeficiency, immunocompromised patient like HIV, and organ transplantation. So here for the morphology, it can be nodular, this one follicular, can be diffuse, can be with large cells and small cells. This is why when you report with large B-cell lymphoma, small cell lymphoma, diffuse or nodular. For the immunohistochemistry, CD3 is for T-cell, mature T-cell, CD5 is for immature T-cell, CD20 is for B-cell type. This is why after the diagnosis of lymphoma, you have to do the CD3 and the CD20 to know if it is B-cell and T-cell. So these are criteria of low grade, intermediate, and high grade. This is for pathologists. For you, it is just to communicate that there is low grade, intermediate, and high grade. For example, high grade, they have large cell immunoblast, lymphoblastic, whereas in low grade, they are mixed small cleavage and large cell. In this one, you see the centroblast. Classification is according to the centroblast, but it is not at your level. What you must know is that there is low and high grade. You see for the grade 1, there are less than 5 centroblasts, larger cells, by high power field. Grade 2, 6 to 15 centroblast, high power field, HPF. HPF is high power field on the microscope. Whereas grade 3 is more than 15 centroblast and high power field. So in the Hodgkin lymphoma, there are common type in Hodgkin lymphoma. For example, this one, Burkitt lymphoma, is an endemic in some part of Africa, including Rwanda, and is sporadic in other areas, including United States. And what I can say, Burkitt lymphoma was discovered first this time in our neighbors in Uganda. Histologically, the African and the non-endemic classes are identical, although there are some clinical and physiological differences. There is a relationship of these disorders with EBV, Epstein-Barr virus. Most of the time, it is the main cause of Burkitt lymphoma. There is the presence of numerous tissue macrophage on the microscope, surrounded by a clear space, what they call star scar pattern. This is the characteristic of Burkitt lymphoma. There are B cells, express IgM, kappa and lambda, right chain, pan B cell marker CD20 and CD20 and CD10. The most characteristic of Burkitt lymphoma is CD10. After diagnosis of Burkitt lymphoma, with the advanced technology, you have to do the molecular testing, where we see the translocation involved the oncogen, MYC gene. I've seen it in general pathology. Those genes involved in cancer. So most translocation fuse MYC gene with the IgH gene on the chromosome 11, but variant translocation involving kappa and lambda chain local on the chromosome 22. So this is that scar pattern. There are macrophage here. This one is scar pattern. Another type of non-Hodgkin lymphoma is mantle cell lymphoma. One unexplained bad characteristic tendency is frequent involved in the gastrointestinal tract, sometimes in the form of multifocal submucosal nodule that result from the polyps. Most of those mantle cell lymphoma, they are found in the GIT. The CD tumor can express IgM and IgD, pan B cell, antigen CD19, CD20, and CD5, and cyclin D. And they have those translocation 11 and 14. Cyclin D is the main characteristic of mantle cell, cyclin D1. Many characteristic on the mantle cell lymphoma. Here it is an image of lymphoma. A follicular lymphoma. This one is the proliferation of those follicles. They say the predominant eosinophilic, they are central site. These tumor express CD19, CD20, CD10, BCL2, and express BCL2. BCL2 is a protein that absent from normal follicular B cells. Because it is those they have follicles, so we have to differentiate those follicles benign or malignant. So on the immunohistochemistry, we have to use BCL2. Once is negative, it is reactive lymph node. And when it is positive, it is a case of follicular lymphoma. For example, this one. To differentiate those nodes with the normal node, it is not easy. But when you go to the morphology of the cells, you see here they have irregular nuclei and more hyperchromatism. T-cell lymphoma. The incidence of T-cell lymphoma is much lower than that of B-cell. A precursor T-cell lymphoblastic lymphoma has been discussed, and it has a plastic large cell lymphoma. There are some cutaneous T-cell lymphoma that include mycosis fungoides, Sézary syndrome, this one the solid and skeletal phase, and the primary cutaneous and aplastic large cell lymphoma. So here there is a comparison between Hodgkin lymphoma and non-Hodgkin lymphoma clinically. So Hodgkin lymphoma, they are more often localized to a single axial group of nodes. For example, it is on the cervical only. or mediastinal or parotid. Whereas non-Hodgkin lymphoma, there are more frequent involvement of multiple peripheral nodes. For example, if you found a lymph node in the cervical, axilla, inguinal, those cases most of the time they are non-Hodgkin lymphoma. Whereas Hodgkin lymphoma, it is found only on the cervical part, only on the inguinal. So another comparison, the order spread by contiguity. Whereas non-Hodgkin lymphoma, they say non-contiguity spread mesenteric node, and the way what they link commonly involved. Contiguity, it means that they are, it is like they are on the same position. Whereas non-Hodgkin, they vary. Mesenteric node and where they link rarely involved in Hodgkin lymphoma. Whereas they are most common in Wardeling. Non-Hodgkin lymphoma, they're most common in Wardeling. They link like tonsils. You have seen it in your anatomy. Extranodal involvement is uncommon in Hodgkin lymphoma, whereas extranodal involvement is common like those in the skin or GIT. Staging of lymphoma, this one is the clinical staging. It is known as Ann Arbor staging, where they say stage 1 is involvement of lymph node region or extralymphocyte lymphatic site, whereas in stage 2 or more lymph node region or an extra lymphatic site in the lymph node region on the same side, diaphragm. Stage 3, involvement of lymph node region on both sides of the diaphragm with localized extrahepatic involvement. Stage 4, their involvement outside the lymph node areas like liver, bones, and the bone marrow. What you must know, stage 1 and 2, they are called early stages because they have a good prognosis. Whereas stage 3 and stage 4, they are advanced stage. Here there is a summary of those lymphoma. Classical Hodgkin lymphoma, these are subtype. In non-Hodgkin lymphoma, there is some indolent, aggressive, and highly aggressive. For example, those indolent follicular lymphoma, small lymphoma. It can be either T, it can be B or T. T, they have a poor prognosis compared to B lymphoma. So the definition, but this one is not necessary to define this. What is a central site? Central site B cell with a cleaved nucleus, centroblast, an activated B cell that is large and proliferating in germinal center of the secondary lymphoid follicle. Menoblast is a lymphocyte that has been activated by an antigen. It is very large. It is mature. So this was the end of the presentation about the lymphoma. So now it is the time for some question and some comments. Question about the lymphoma, Hodgkin and non-Hodgkin lymphoma. Question? Are you together? Question?
Yes, sir.
Yes. Question? Question?
Question.
Good afternoon.
Good afternoon.
Hello.
Yeah, you're welcome.
Sorry, I had some internet issues. I didn't understand well how follicular lymphoma is formed.
Sorry?
I didn't understand well how a follicular lymphoma is formed.
Normally, what you must keep in mind in the case of the lymphoma, on the microscope, there is effacement of those nodules, if you still remember the anatomy of the lymph node. So, whereas in the case of lymphoma, there is no effacement of those nodules, but there is proliferation and increase of those follicles. So, you can confuse follicular lymphoma with a reactive lymph node, which has many follicles. So to differentiate them, normally in follicular lymphoma, those follicles are very large and tight. And to be sure, you have to use immunohistochemistry. Use an antibody called BCL2. This one, BCL2 is absent in reactive lymph node, the normal lymph node, whereas it's positive in follicular lymphoma. This is how we differentiate follicular lymphoma from a normal lymph node. Is it clear? Is it clear? Clear?
Yes.
On this image, if you see found those nodules, you can think it is a normal follicle. Whereas it is a follicular lymphoma. This is why you must be careful in differentiation. Lymph node, normal lymph node and follicular lymph node.
Another question.
Mm-hmm.
How should we diagnose the Hodgkin lymphoma?
Sorry?
How should we diagnose the Hodgkin lymphoma?
Even in the audience, there is an answer. Who can tell us the characteristic of a Hodgkin lymphoma on the microscope? Even in the audience, you can ask. Can tell us the characteristic of Hodgkin lymphoma on the microscopic examination.
Hyperchromatism.
I was asking diagnosis.
Mm-hmm.
Diagnosis of Hodgkin lymphoma and how we can treat it, if it is surgically or anything.
Maybe you were here but absent. I have said there is no treatment, no surgical treatment for lymphoma. Always it is radiotherapy and chemotherapy. Okay? Because if the chemotherapy, the tumor will be shrunken. Mm-hmm. So in the audience, what is the main characteristic of Hodgkin lymphoma?
Resistant back cell.
Yeah, very good. It is the presence of red Sternberg cells. Once you found this cell, like this one, in that case you are dealing with a Hodgkin lymphoma. Okay? Any question?
Question. Oh, so how non-industrialized countries are linked to lymphocyte depression in Hodgkin lymphoma?
Yeah, for this one, it is like epidemiological. Most of the time, there is no known causes. The cause is the unknown. It is found there in epidemiology that they found most cases in those non-industrialized countries, but the explanation is not clear. Okay.
Okay, thank you.
Another question?
Question. In the case of lymphoma, if the affected B cells reach in the blood system, is it still called lymphoma?
Sorry?
If the affected B cells reach the circulation system in the blood, I'm asking if it's still called a lymphoma.
What is a lymphoma?
Malignancy of lymph nodes. The malignancy of lymph nodes.
Lymph node or lymphocyte?
Lymphocytes, sorry.
How many types of lymphocyte?
We have two.
Which and which?
B cells and T cells.
Yes. Which one has a good prognosis? T cell or B cell lymphoma?
B cells.
B cell they have a good prognosis.
Yes. Okay.
Another question? Another question about lymphoma. How many types of Hodgkin lymphoma? Who can give us the answer?
Four.
Hmm?
Four.
Which and which?
Five types.
There are nodular sclerosis,
Hmm?
multiple cellularity, lymphocyte depleted, and lymphocyte rich Hodgkin lymphoma.
Hodgkin lymphoma. It's not correct. Repeat again.
Also mantle cell lymphoma.
Mantle cell lymphoma, is it a Hodgkin lymphoma or non-Hodgkin lymphoma?
Non-Hodgkin.
So what are the subtype of Hodgkin lymphoma? The subtype of Hodgkin lymphoma.
Nodular sclerosis.
Another one?
Lymphocyte rich.
Another one.
Lymphocyte
Multiple cellularity.
depleted.
Multiple cellularity is not there.
Mixed cellularity.
Mixed cellularity. Another one.
Nodular lymphocyte predominant.
There is nodular sclerosis, mixed cellularity, lymphocyte depleted, lymphocyte rich, and nodular lymphocyte predominant. Which one has the popcorn cells? Which one has a popcorn cell?
Lymphocyte predominant.
Nodular lymphocyte predominant.
Yes.
Which one has a good prognosis? Which one has a good prognosis? Nodular sclerosis and there are two types with an excellent prognosis. Which and which? There are two types of good prognosis. Which and which? Who can give us the answer?
Nodular sclerosis.
And what? Nodular sclerosis, another one.
Lymphocyte depleted.
No. Nodular lymphocyte predominant. This one has a excellent prognosis. What are the markers of red Sternberg cells?
Question.
Yeah.
What's the difference between diagnosis and prognosis?
We need the audience who can give us the answer. The difference between diagnosis and prognosis. Hari abajya babetinga aho ngaho ku mipira.
Diego,
What is a prognosis?
predictions. Is the
It's an outcome.
something?
What is a prognosis?
Prognosis is the prediction of the occurrence of a disease.
Yeah, it is the prediction. For example, when we said it has a good prognosis, meaning that the survival is higher than the others. Okay. Do you understand the prognosis? The prognosis is to predict overall, overall the outcome of a disease.
So you can, prognosis is under diagnosis.
my friend. I'm wondering if you are in medical school or in arts and humanities or social sciences. What is the diagnosis? You have done clinical skills. A diagnosis is the confirmation of a disease. For example, if we say lymphoma, this one is the diagnosis. If we say prognosis of lymphoma, nodular sclerosis, the survival rate is 100%. This one is the prognosis. Okay?
Okay.
Is it clear? Mwize clinical skills cyangwa ntabwo murayiga?
Twarayize.
Nibyo rero byakagombye kuba biri kumenya diagnosis, what is diagnosis, what is the prognosis.
Question.
Yes.
My colleague asked about the Hodgkin lymphoma, and you tell him that it is marked by T cells. It means that for non-Hodgkin lymphoma, it is marked by B cells.
Sorry, I don't understand clearly the question.
My colleague has asked the question about the markers for Hodgkin lymphoma, for how we can determine it is Hodgkin lymphoma, and you tell him that it is marked by the T cells, the presence of T cells. And I wonder if for non-Hodgkin lymphoma you can make it by presence of B cells. It can be the inverse. For non-Hodgkin lymphoma, you can see the B cells are dominant.
No, most of Hodgkin lymphoma, they are B cell. Non-Hodgkin lymphoma, they can either B cell or T cell. And my question was this one: what is the markers of red Steinberg cell? What are the markers? What are the markers of red Steinberg cell? The markers of the RS red Steinberg is CD30 and CD15. This one you must know. It is done on immunohistochemistry. Is it clear?
Yes.
Okay. Is it clear?
Yes.
Okay. So as you see, we have time. I can explain more, maybe in 10 minutes like that, about what we call myeloma. It is what we call plasma cell neoplasm and related disorders, also known as myeloma. The cells involved, they are plasma cells. Remember that plasma cell different in plasma protein. We have seen it in histology and general pathology. Those they are B cell proliferation, contain neoplastic plasma cell that usually, so that virtually always secrete monoclonal.
Excuse me, Prof, we can't see the slide.
Yes. Sorry?
Excuse
We
us.
can't see the
sir.
slide.
Yes.
Sorry?
We can't see the slide you are presenting.
It is not, you don't see the presentation.
Yes.
Maybe it was because of the internet connection. Can you see it?
Yes, we can
Yes.
now.
You see now the image?
Yes.
Okay. So those plasma cell, neoplasm, and red disorders. Plasma cell, those that are from B cell proliferation, and they can secrete immunoglobulin. Collectively, the plasma cell neoplasm, often referred to dyscrasia, and they count about 15 of deaths caused by lymphoid neoplasm. And the most common and death of death neoplasm is called multiple myeloma. This one we found it in your clinical practice. The terms used to describe the abnormal immunoglobulin include monoclonal gammopathy, dysproteinemia, and paraproteinemia. So the following clinical pathological entities are associated with monoclonal gammopathy. For example, multiple myeloma. This is the most important monoclonal gammopathy. Monoclonal means that there is one cell type involved in that disease. Usually, they present as tumorous masses scattered throughout the skeletal system. Most of the time, they are on the bone. It can be multiple or solitary when it is a single tumor. It is called plasmastoma, and is an infrequent variant that presents as a single mass in the bone or soft tissue. Smoldering myeloma referred to another common variant defined with lack of symptoms and the high plasma with M-plot component. Solitary myeloma is called plasmastoma. Smoldering, this one referred to another common variant defined by lack of symptoms and high plasma component. I've seen it. There is another one called Waldenstrom macroglobulinemia. This is a syndrome in which high level of hemoglobin, IgM, lead to the symptoms related to hyperviscosity of the blood. This one occurs in older adult, most common association with lymphoplasmatic lymphoma. There are some primary and immunocyte-associated amyloidosis, result from monoclonal proliferation of plasma cells. In the secret light chain, usually gamma is the type that are deposited in amyloid. Some patients have overt multiple myeloma, but others only a minor clonal population of plasma cell in the marrow. Some have chain disease. This one they are rare monoclonal gammopathy. This one is an association with a diverse group of disorders, including lymphoplasmatic lymphoma and usually small bowel marginal zone lymphoma that occurs in malnourished population and so-called Mediterranean lymphoma. A common feature in the synthesis and secretion of free heavy chain fragment. Monoclonal gammopathy of intermediate significance is applied to patients without signs or symptoms who have small to moderate large M component in their blood. Monoclonal gammopathy of intermediate significance is very common in adult and has low but constant rate of transformation to symptom monoclonal gammopathy. Most often, multiple myeloma. So those are some variants of those multiple myeloma. But let us see in general what is a multiple myeloma, because this is one you must know. Multiple myeloma is B lymphoid malignancy, which is characterized by proliferation of a malignant clone of plasma cell, which synthesize and secrete excessive amount of monoclonal hemoglobin. Multiple myeloma is the disease of elder group, with the main age is 62, but we have seen some cases about even 50, like that. We have some cases. Many myeloma have rearrangement involvement in the immunoglobulin heavy chain gene on that chromosome 14, Q32. These are some genetic involved in multiple myeloma. I have said before, even in general pathology, once you have a cancer in advanced technology, you have to do also molecular test to see the gene involved in that tumor. This is why you see some gene mutation in this multiple myeloma. So on this image, you see the blood stem, myeloid stem cells, they develop myeloblast. For lymphocyte stem cells, lymphoblast, B lymphocyte, and you know that after B lymphocyte encounter an antigen, this will become plasma cells and then start secreting antibodies. And the plasma cell, there are cells involved in those multiple myeloma. Clinical features, 70% there is bone pain. There is lytic lesion in the bone, site involvement is back, lips, pain precipitated by movement. So once you found in elderly people with the bone pain, lytic lesion, you may think about the myeloma. This one, it is found with a pathological fracture. When you see in the elder, on the X-ray, you found a fracture without a physical injury. Most of the time, think that you are dealing with multiple myeloma. The same as a spinal cord compression due to collapse of the vertebrae. This one, you may think that you are dealing with the multiple myeloma. There is increased susceptibility to bacterial infection, and the most common infection associated with pneumonia and the pyelonephritis. Organisms in the lung, like those Streptococcus pneumonia, Streptococcus aureus, Klebsiella, in the urinary, Escherichia coli, and other gram-negative. You have seen it in your bacteriology. It can have renal failure. It can have hypercalcemia, tubular damage, glomerulonephritis, glomerular deposit of amyloid, and hypersemia. Glomerular function is usually normal, but proteinuria is uncommon. But those are associated features, they're not the main features. The main features are bone pain and lytic lesion. Anemia is also found, normocytic and pneumochromatic. Some have megaloblastic anemia. You will see it in your hematology, craniocytopenia. Clotting abnormalities may be seen. Deep vein thrombosis. And the main characteristic also, M protein is strongly antiphagocytic and is a major variance risk factor produced by those streptococcus. So in multiple myeloma, we found M proteins. Hyperviscosity, this one you see it. This one is not necessary. Variant of myeloma, it is important. When it is solitary, they call it plasmastoma. Can be extramedullary when you found in submucosal lymphoid, nasopharynx, paranasal sinus, without myeloplasmostosis, but rarely this one occur. Both, they are highly responsive to local radiation therapy. Diagnosis, this is the most important. Diagnostic investigation. There is plasmastosis in the bone marrow, meaning that there is an increase of plasma cell in the bone marrow. They say plasma cells more than 10, around 10 to 50% present of abnormal form myeloma cells, such as less clamping of nuclear chromatin, large nucleoli, and large open nuclear zone and lighter blue. These are features of abnormal plasma cells. In that case, you deal with multiple myeloma. But if you found three cells of plasma, don't think that you are in multiple myeloma. There must be abundant and increased cellularity of plasma cells in the bone marrow. Here they say a flow cytometry. Flow cytometry is a machine used for the diagnosis of those hematopathologic cancer. A flow cytometry of aspirate can be used to quantitate the malignant plasma. Monoclonal proteins in serum or the urine. M protein must be there. The cellular formation is characteristic but not specific. That may be another condition in which Ig immunoglobulin level are elevated, such as lupus erythematosus and ear infection. These are some associated. This one can even cause confusion. But the most important for multiple myeloma is an increased cellularity of plasma cells, and most of the time you can see some viniculated plasma cells. In that case, when you found that image on the lab, think that you are in multiple myeloma. On the image, radiologically you see some lytic region of the bone. In that case, you may think in elderly people, you can think it is multiple myeloma. Even here. There are some asymptomatic multiple myeloma, but that M protein is superior than 30 gram by liter. Bone marrow monoclonal plasma, it is an increased more than 10%. In that case, no myeloma-related organ or tissue impairment, including organ damage in the bone region. M protein must be there. I think this one is not even necessary. You read yourself when you have time. Other investigation. See, M protein, you must know criteria for diagnostic multiple myeloma. First of all, plasmastoma on the tissue biopsy. Tissue biopsy is most important. On the bone. Bone marrow also is necessary. Monoclonal gammopathy, monoclonal immunoglobulin. GG and idosis, bone marrow plasmastosis between 50 and 30, less IgG. This is about the staging until now. Maybe when you have the time, you can read. These are some disorders associated with monoclonal proteins. I've seen multiple myeloma, solitary myeloma, or Waldenström heavy chain. I've seen it at the beginning. This one also some disease associated. The treatment is using chemotherapy in summer, is the chemotherapy and the radiotherapy. So I think this one is not necessary. About the treatment, you will see it in your clinical practice. The major cause of death in the case of multiple myeloma is progressive myeloma, renal failure, and sepsis. Maybe here there's some question. At the time of diagnosis, the peripheral blood film of a patient with multiple myeloma typically show a greater than 10% plasma cells, marked lymphocytosis, neutropenia, rural formation. What is the answer? What is the answer? What is the answer? Who can answer the question? Are we together?
Yes, sir. I can try. I think it's B.
Why? It's not a betting.
The answer, I think, is D.
Yeah. You can give the explanation.
Because of increased immunoglobulins.
Because of, look at the question. At the time of diagnosis, the peripheral blood film. Do you know what is peripheral blood film? That is layer of the blood. A patient with multiple myeloma typically shows.
I can try.
Mm.
For me, I think the answer is A, because you said that in multiple myeloma, it shows the main features is the more plasma cells greater than 10%. Thank you.
Yeah, the answer is A. Because multiple myeloma is characterized by an increased number of more than 10% of plasma cells. Serum protein electrophoresis appear to be normal. The laboratory should do. Repeat the serum protein electrophoresis. Measure plasma viscosity.
I can try. For me, I can say that the answer is C. You can measure the plasma viscosity because in multiple myeloma they say that there is hyperviscosity of the blood. Thank you.
Yeah, very good. Okay, number 3. A patient bone marrow is found to have an increased number of plasma cells, plasmocyte, lymphocyte, and mast cell. The patient cell are most like an M protein composed of what?
For me, I can try by saying that the answer is B. That patients cell mostly have the immunoglobulin M.
Sorry?
I said that the answer for me, I can say it is B, immunoglobulin M.
Mm-hmm. Yeah. Number 4, which of the following manifestation of multiple myeloma would be least likely to be seen on the chest X-ray features? Which one is the least likely to be seen on the chest X-ray? Lytic lesion, associated limb fracture, multiple lytic lesion, vertebral ramification and collapse, plasmastoma during coin lesion in lung periphery. What is the answer?
I can
I
try
think
by
we
saying
get
that the answer can be D.
D.
Yes.
Why? Can it be D because the plasmacytoma, most of the time it is solitary. Number 5. Abnormal protein frequently found in the urine of the person with multiple myeloma is
As you have seen in the first question, the immunoglobulin M is the one which is present in the urine of that person with multiple myeloma.
which one?
Immunoglobulin M.
Who can give us another answer?
I think is Benz Jones. D.
The answer is D. Benz Jones proteins in urine. So in your clinical practice, once you found multiple myeloma, then you ask electrophoresis of the proteins. Then they give you the Benz-Jones proteins, and the electrophoresis of protein is available. Even here at CHUK, we have that machine for electrophoresis. Okay. So you have to understand Benz-Jones proteins. While dextromicroglobulin is characterized by an increased level of
The answer is B.
is associated by
Increased level of IgM.
Sorry, I have a problem on my computer.
IgM.
Don't know what happened on my computer.
amafoto aracyayafite.
ariko nka 16.
Hello, class. Can you hear me?
Yes, sir.
Yes.
Yes.
Okay, there was a problem on my computer. The question was there. Hello, can you hear me?
Yes. We are hearing you.
Yes, we are getting you, lecturer.
Can you hear me? Yeah,
Yes,
the answer was IgM is associated with the Waldenstrom microglobulinemia. So now my computer has a problem. I think we can stop here and prepare for the next week presentation. On Wednesday, you will continue with Dr. Benson, and I will come on Thursday. Any question before we close?